Good afternoon, all. Thanks so much for joining us today, and sorry for the delay there, just a little technical issue on our side, but we're really excited to have you here. So thanks for spending your lunch hour with us today to discuss earning non-dues revenue through public health initiatives. My name is Annie Kropik. I am the Assistant Project Coordinator with Twin Cities Medical Society's Physician Advocacy Network. Before I introduce today's speakers, I want to go over a few quick housekeeping items. A recording of the webinar will be emailed to each of you at the conclusion of the webinar, so you can view it, share it with your staff or board or others who may be interested. All participants are currently muted, and you'll remain muted for the duration of the webinar. We have some time set aside at the end of the webinar to field questions. So if you have a question as we go along, please feel free to type it into the chat box, either as we go or at the end, and then we'll have the speakers address those at the end of the program. So I'm going to introduce to you today our speakers. Our first speaker here is Dr. Pete Donnell. Dr. Donnell is a board-certified pediatrician who has been in practice for 30 years. He's been actively involved with Twin Cities Medical Society public health initiatives and organized activities, including involvement with the Honoring Choices Minnesota movement. Dr. Donnell is the current medical director of the Physician Advocacy Network and leads physician education about alternative forms of tobacco use and encourages physician leadership in the form of advocacy. Dr. Donnell has been involved with efforts to reduce tobacco's impacts on the lives of people for over 15 years, with tenured involvement in city, county, and state efforts to eliminate secondhand smoke and include e-cigarettes and smoke-free ordinances. Dr. Donnell received the AMA's Benjamin Rush Award for Citizenship and Community Service in 2012 and Twin Cities Medical Society's First of Physician Award in 2014. We also have Sue Schottel with us today. Sue is the CEO of Twin Cities Medical Society, which represents over 4,000 physicians from the 7-county metro area of St. Paul and Minneapolis. She has been the CEO for 11 years and has led much of the non-dues revenue growth for the society. Her experience in fundraising, program development, and program management has led to some significant public health advancements in Minnesota, including smoke-free policies, obesity prevention efforts, and helping to normalize end-of-life care conversations. Sue is an Emmy Award winner for a series of documentaries that were produced to empower people to have end-of-life care conversations and has co-authored a book on the same subject. She has consistently been named one of the top 100 most influential healthcare leaders in Minnesota. And with that, I will hand you all over to Sue.
Hi, everyone. Thanks for participating today. By way of background here, you know, like many associations over the past decade, we have seen a decline in membership, and I'm sure that's not a new thing for many of you on the call today. You know, we have challenges, all associations have challenges, and we were experiencing that just like many of my colleagues from across the country. You know, independent clinics are, we're seeing fewer and fewer of them in the state. They're being swallowed up by some of the larger healthcare systems. And so when I was hired, actually, as the CEO, my leadership had a pretty good idea that this was going to be something that was a trend that was not going to go away. And so what they did is they challenged me as the new CEO to come up with an alternative model for sustaining the organization. And so we did that. We started off actually doing our work trying to do things like offer lab coats for less money, you know, give our physician members discounts on insurance products and things like that. That was modestly successful, but it was very time intensive. And so what I ended up doing then is looking at an alternative model that would, you know, bring in more revenue and consistently bring in revenue. And this happened to be right around the time when the smoke-free movement was happening in our state. And so that just sort of launched us to our model of non-dues revenue, adding physician involvement, and then advancing public health priorities. So what is public health? You know, Dr. Donnell will talk about this concept in more detail when he gets the slide deck here. But briefly, public health initiatives are projects that go beyond the clinic walls, and they address health from a broader perspective, not in a siloed perspective, but really looking more at the full community. You know, it's a Public health projects seek to make changes that impact the health of many patients and the community as a whole, as opposed to medical care that is, typically one doctor, one patient. And having a hands-on role in public health is a departure from what medical societies have historically and typically done, in terms of policy work and things like that. But it's really been something that's been helpful for my society. So why medical societies and public health? Why is that a good fit? I'm sure I don't have to tell you that medical societies and associations have the ability to attract healthcare leaders from the healthcare systems. And so my board of directors, many of whom come from the healthcare systems, they're chief medical officers, they're medical directors, and so they're already part of our association. And we know them, and they typically, know us. We're also, medical societies are neutral turf. We really don't see, obviously we don't see patients, so we're not competing for patients, but we can convene partners around the table to advance policies, or to advance work. In a lot of cases, we also have access to the medical school, so we're able to work with medical students, many of whom are members. In Minnesota, they're all members, so we have access as a medical society to work with medical schools. And the bottom line that I have found is that funders are definitely excited to fund physician involvement in public health. As an organized physician organization, we can make big things happen. So our funders are excited to fund our work. Our model really has three, segments to it. So we educate physicians, we engage them in public policy, and we empower them with tools and resources. Move my slide here. We call this model PAN, or Physician Advocacy Network, but the acronym is PAN. Excuse me. So PAN educates physicians on public health topics through free, evidence-based, in-person trainings and workshops. We do online webinars and toolkits. We educate physicians on public health topics like e-cigarettes, tobacco, and advanced care planning. We prepare physicians to better provide clinical care and prepare them to act as advocates on these issues. What we get out of this as a medical society is that we have leaders that are now connected to us because we are advancing this work, and they might not otherwise have had any connection to us for any of the other things that we've historically done. So it's a win-win. PAN engages physicians in discussions around public health topics. We do this in a variety of ways. Our staff members work closely with physicians and community groups and other stakeholders. They are able to build connections between the medical community and the community groups themselves, so making that connection with physicians and the local community is important. This allows us to connect docs with opportunities to support work that's happening in their community, in their city, or in their county. And as a county medical society, this was attractive to me because we're trying to not compete with our state association. And so when we developed this model initially, it was to work in the cities and the counties that where most of our members come from. So PAN engages physicians in discussions. And then lastly, we empower physicians to become leaders in public health by providing training. It can be from issue-specific training, so training them on what we know about e-cigarettes, for example, and also media training, help them to figure out how they can be the most effective communicators. And we found that physicians want to be involved in this work, they just aren't always sure about how best to do it. But we have enough experience to help empower them to become strong advocates. And you might know as well that physicians and medical students are very credible messengers. I've seen time and time again that they're allowed more time on the agenda, for example. They're asked questions by elected officials because they understand that physicians base their opinion on science, and that's been a helpful reason, or that's been helpful as we try to advance some of our work. All right, I'll talk briefly about some of the projects that we are leading or have led through the Medical Society. You know, prior to 2007, I really didn't know what advanced care planning was. It was one of those things that I thought it was, you know, a healthcare directive, but it's actually, it's much more than that. We launched a program in 2007 called Honoring Choices Minnesota. We were looking for a project that would increase our profile and at the same time increase our non-dues revenue. And so we landed on this idea that, hey, can we do end-of-life care planning better as a community? And so we had consistent support from the healthcare system leaders to go ahead to do that. So we've been leading that work since 2007, and quite frankly, I don't see an end in sight. We've trained over 4,000 people to have end-of-life care conversations. They're called facilitators. And we are working throughout the state. We hadn't intended that to be the case when we launched, but it has actually gone that way. And actually, it's a national project as well. We're working in 12 other states. And then we also have a diverse funding stream with that project. We have private funders. We also have a state appropriation that came out of our legislature. And we've gotten it once, and we're applying for it a second time, and I'm optimistic that we will get that. This next project that we're working on really sort of goes over top of Honoring Choices. It's called the convenings, and as the name implies, it's a convening of people. And we are using a person in Minnesota who's well known. She's the morning drive person on Minnesota Public Radio, so her voice is very well known, and she's personally passionate about this issue. And so we've been working together with her to get people to attend events, and then once they attend the events, we give them the resources to go home and have those conversations. This brought in additional money to the society as well, and we are actually having a much bigger impact getting people to excited, I think, about having conversations about end-of-life care. We have a waiting list of 20 additional cities that we're hoping to engage as we look at a 2.0 of this project. I feel like I'm going really fast, but I know we got started a little bit late, so I'm trying to be respectful of all of your time and offer, you know, a chance for questions. So, tobacco control. So we've been working on tobacco control for as long as I've been with the society. I've actually been here a total of 15 years, and when I first started here, we began to work on tobacco control with Dr. Donnell, actually. And so we have been funded consistently to work on tobacco prevention. Right now, we're working on e-cigarettes and other flavored tobacco products. So we've got a lot of experience in tobacco control. In the early, whoops, let's forget the slide here. In the early 2000s, you know, we played a major role in passing many of the city and the county level smoke-free ordinances. If there are people on the call who don't have smoke-free policies within their state, I would encourage you to look at that and see if you might be able to take a leadership role there, because having physicians in the center of this debate has been one of the, I think, more important things that we have done as TCMS for the state of Minnesota. We had more than, you know, when we first were funded to work on this, we had more than 400 people, 400 docs and medical students contact us and want to be involved in the work that we were doing. So, and that was actually just in the city of Minneapolis. So that wasn't even in any of the other communities that we wanted to work in. So what I'm saying is that it's a great place for the medical society to be because physicians really get the issue of the harms of tobacco. And so what we did, we worked locally with with the other county medical societies in our state to help them replicate this model within their region. And then once you hit a certain, you know, mass of ordinances that ban smoking indoors, our state association took it from there and was able to get a statewide smoke-free law passed in 2007. But that wouldn't have happened had we not had so many physicians involved in the work. As I've talked about a couple of times, TCMS has launched another tobacco-focused project on e-cigarettes and other tobacco products. And we've labeled, I guess, our work the Physician Advocacy Network because it's spanning the state, and we really have a lot of physicians that fall under this work, so we named it the PAN. We've educated almost 2,000 healthcare professionals in more than 70 sites from across the state. So these are docs, nurses, social workers, community health workers, but our target is primarily physicians. And we do have CME that's available for physicians that need that. And we are also working, we have also worked to support 26 local policies around e-cigarettes, and then 7 statewide policies. So there's a lot going on with this work in tobacco control. The next slide here is, and probably, I think this is probably in the mid-2000s, we were funded to work on obesity prevention. We had a 5-year contract, and it ranged from working on healthy eating, active living strategies to, encouraging cities to have bike paths and community gardens, and working on menu labeling to show the calories, and phasing out trans fats. So physicians were very involved in that work as well. And we're hoping to do some work in diabetes prevention as we look to the future. Now I will ask Dr. Donnell to take it from here.
Thank you, Sue and Annie, for your comments, and this is a great place to start the conversations. If you are working with physicians and you aren't doing any sort of a population health or public health activity related initiatives, please consider doing that. If you've started but you want more assistance in how to format that and how to get it going, please contact us, and we may have some ideas that will help. But at the end of the day, this is a great place for physicians to be operating. And what I mean by that is that many of us, as we go through training, we learn very much about how to work one-on-one with patients and families, and that's a very important place for physicians to be working, of course. But on a bigger scale, we also need physicians to be engaged in more population health-based initiatives. We need their engagement in many important health issues that need to have an earlier community-based focus or an earlier public health-based focus, whatever term you want to use. Sometimes if we think about public health in a very narrow sense, we think about public health clinics, but we need to think about the much broader issue of how to create healthier communities in which we live and practice. And so that's what we've been able to look at and have some activity and success in the Physician Advocacy Network, because we've been able to take that concept and more formalize it into ways to get physicians engaged on some very important issues. On the slide are just some of the different areas that many communities around the United States really need some assistance with. And there is a role of population health in all of these issues that you see on the board: diabetes, stroke, cancer, obesity, mental health issues, and just health in general. Cardiovascular disease is a big issue that we really need to figure out a different way of addressing that issue than what we are currently doing. And the physician advocacy efforts are how to get to that point. One of the things that physicians aren't necessarily used to thinking about is how can I exert my influence outside of the walls of my clinic? Physicians do a great job within the walls of their clinic. They do a great job of taking care of their patients. They do a great job of providing health advice and prescriptions for improvement. But when those patients go into their community, if they have a more supportive community, for example, if you don't have to confront secondhand smoke in a restaurant, your cardiovascular disease issues will be less. If you have healthier communities where there are bike paths and it's more pedestrian friendly, you will have healthier outcomes. But a lot of times physicians will need some help in formalizing their opportunity to work in that space, and so that's what we've been able to do with the Advocacy Network, and it's been very successful. One of the things that I remember from my early days of working with the tobacco issues is that, and this was as many years ago as Sue was referring to, 15 years ago, I was just happened to be at a lunch meeting with a local city council member, and she said, I can support this whole smoke-free public space idea, but if this is such an important health issue, where are the physicians? And to her point, it was very true. We did not have a lot of physician engagement at a public level that was needed to help support the issue, and so that was one of the things that we were able to do back in the 2000s in terms of helping to support the community's efforts to reduce secondhand smoke, and then that led to eventually to the statewide ban that we have in the state of Minnesota. So it's one of those things where when physicians are engaged, you can really see some improvements in population health and public health issues. But again, it needs physicians who are willing to come to city council meetings, willing to write letters to the editors, willing to meet one-on-one with their local elected officials to help explain why this is an important issue for them to support as elected officials. One of the examples that we have here, and this is just one example of, as Sue mentioned, we had over 400 people that were involved back in the 2000s in terms of the Freedom to Breathe Act. This is Dr. Schultz. He is a member of our TCMS board, but he is also a commissioner on the Edina Public Health Commission. He was able to successfully lead an effort for Edina to become the first city in Minnesota to raise the tobacco purchase age to 21. And that's just one example of where you have a physician who's willing to step up to the plate and get engaged with promoting an important public health issue. And again, as Sue had mentioned, there were a number of physicians involved with the 2000 initiative, and they are continued today in terms of the electronic cigarettes and other flavored tobacco products. And we've had some recent success in the city of Minneapolis in that regard as well. So now the question in getting at the very root of this is that who benefits from this? Okay, it's nice to have physicians engaged. It's nice. It sounds good. It's one of those things that in a broad sense you can say, yeah, physicians should be doing that. But really, there is a lot of benefits to all people who are engaged in this. And first of all, how do physicians benefit from this? They can develop new leadership skills. It gets very uncomfortable when you first start doing it in terms of working with a more public venue, in terms of being a physician and advocating for certain public health issues. And I remember the first time I stood in front of a local city council meeting, it felt very awkward to be up there. But with time and with some training and some needed assistance from people who know how to do this, I was able to feel more comfortable, and I hopefully have been effective in that space. It's also a way to learn about how you can really impact these public health issues like obesity, cardiovascular disease, diabetes, various cancers. And there's a different knowledge set that physicians don't necessarily pay attention to in their day-to-day lives, but when they see, oh, there is a public health opportunity here, or a population health based way that I can really help my community to be healthier. There's a way to extend their caring about their individual patients to their community as a whole. And then finally, it's a way that you can actually see some very tangible improvement of the health of your community. through this kind of activity. How does the community benefit? There is a great benefit to the communities. You have people who are a little less likely to have the initiation and progression of diabetes. That's a huge issue that's coming up from a public population health perspective. And you have healthier patients. And you can prescribe antibiotics, you can prescribe cholesterol-lowering drugs, but if they simply get out and get to be more healthy in terms of their physical activity, you can reduce some of those need for more advanced treatments and get them healthier and being able to engage in life at a higher level. And so then an equally important question is, how does your society or how does your organization benefit from this kind of activity? As Sue has mentioned, it has been an important source of physician engagement from the Twin Cities Medical Society to get physicians engaged. And it really doesn't matter if you're still in an independent practice, which there are fewer and fewer of as we are seeing consolidation. You can be an employed physician in a large health system and still see the benefit of becoming involved in advocacy efforts. And that will also then help to engage that large health system at a higher level than what they might be otherwise. Non-dues revenue is a very important thing. As we are looking locally at our own medical society, this has been a challenge. But with seeking revenues outside of membership dues, this is a way to help support the activity of your society or organization in a new and hopefully successful way going forward. It helps to enhance and reinforce the notion of what physicians oftentimes went into medicine for. It's a way to enhance their place in the community, and that's something that a lot of physicians feel is diminishing. But if they can be out there advocating for the benefit of their community and for their patients outside of the walls of their clinic, it's seen as a very positive thing. It's a way, hopefully, to enhance physician membership within your organization. It's a way to create new value for your members that are continuing to renew their dues on a yearly basis. And it's a way to pitch membership for not only the individual physicians, but for the health systems. What we are seeing more and more have a role in our community, in our medical systems as well. And then finally, this is a way that really helps to fill a void that would otherwise be left untouched by any other organization. There's really nowhere else that you can see this kind of importance of physician engagement if it's not done in an organized way through these kind of population health-based activities. So I would really truly encourage everyone to look at how you can engage your membership and your physicians in a new and beneficial way. And again, it's beneficial to the physician, it's beneficial to the communities in which they are practicing, and then finally it is certainly of benefit to your organization or medical society, because again, this is something that's new thinking in many ways. It's going beyond simply membership dues, but it's a way of doing everything in the right way for the right reasons. And with that, I'm going to hand the mic back to Sue.
Clicker.
No, you can't have the clicker. Sorry.
All right. So how can we help your organization? So we were awarded a 2-year grant from the Physician Foundation to help other county and state medical associations, which includes specialty societies and others, but to help them adopt a similar model to what we've created here in Minnesota. You know, we have resources that come with this grant that can, so basically you wouldn't have to pay for us to come and visit you and meet with your board. Whoops, sorry, I'm off a slide. There we go. So we're lucky enough to get a grant to help expand the model. You know, we can provide your organization with a roadmap. Pete and I have been doing this work for a while. And when we started, I'll speak for myself, when I started, I really didn't know what I didn't know. And so I didn't have really a mentor in terms of there may have been another county or state medical society exec out there that I could have, you know, tapped into, but I didn't know who they were. And so, you know, the roadmap is something that it's I mean, obviously the word implies that we have a sort of a document that we can give you, but it's that and the experience that both Pete and I have in doing this work. You know, and the other thing is we look at this, I always look at this from the perspective of a physician lens. So, you know, we have a unique space here in public health because of that whole MD degree where physicians are trained to understand diseases, obviously, and so when they speak on topics related to public health, I know that they get the attention of people that make policy. Okay, so what we can offer, Pete is Dr. Donnell is our medical director, and he can provide on-site training. We've done this a couple of times last year, or earlier this year, I should say. And so what we do is really look at more of a one-on-one conversation with Dr. Donnell and your leadership to help sort of envision what you could do as a medical association in the area of public health. As I mentioned, we have resources to support travel, so the cost would be very minimal, if nothing. We have a couple of different resources we can bring your way. You know, I have two staff members that are devoted to tobacco, Annie and Grace, and they along with Dr. Donnell have created a toolkit that includes resources that physicians would need if they're wanting to delve into this topic of e-cigarettes. So there's actually a sort of a packet of stuff that you get as part of the e-cigarette work. And the advanced care planning, honoring choices work is similar. However, as I mentioned earlier with that, when I was talking about honoring choices and how it, you know, started and where it is now, it is becoming a national model. And so we have definitely resources. We have a different medical director that could come in and speak to you if Pete is unavailable to talk about honoring choices. But then in addition to that, we have other resources that you would have to pay for, which is, you know, the name and then also consulting services. But that's down the road. But so of the two issues, the medical director component of it is free. It's just you're needing to figure out what it is that you're interested in doing. What else do we offer? Personalized technical assistance and mentoring. So, you know, Dr. Donnell can help to find a medical director, and I would advise on any public health priority that you have that you need to have a physician lead to take this on, because it's good for the medical society to have a physician out front on the issues, and it's good for you because you know, you could rely on one of your members to help carry this forward. We can help you look at potential funders, and I'll talk a little bit at the end here about our funding stream. And we've also provide you with copies of our grants. We've written a lot of grants, and sometimes it's just helpful to look at how, you know, a medical association has formatted their grants and how they explain who they are and what value they bring to public health priorities. We also help with, you know, the making the ask. I know when I first started this work, I was terrified to ask for money, especially the numbers that we were looking for. And so what I did is surrounded myself with physicians and others who were really comfortable at raising money. And then I sort of learned the ropes, and I would encourage you to do the same. And then we can help you coalition building and community partner building. We've been doing this for a while, so we can help you with that. And then lastly, how do you communicate and engage your members in the work that you're doing? Okay, so with that, we put together some frequently asked questions that we get. And I would encourage you at this point too, if you have questions that that you've thought about along the way here, I'd encourage you to put that into the chat box. That's the word, chat box. And then we'll try to answer your questions after I get through these next few slides. Oftentimes we get questions about, do you only involve members in the work that you're doing? And the answer is no. It's been my philosophy that you have to prove value to physicians that are not members. And one way to do that is to engage them in the work that you're doing and prove yourself basically to them. And this has been something that not everyone agrees with, but I can tell you that from the early days of working on tobacco, some of the people that were involved in that 400 number that we keep talking about are either on my board now, or they're involved in some way, or they are a lifelong advocate and they are members. So it's a strategy that's not your traditional way of doing things, but it's worked for me. So no, members, I involve members and non-members in the work. Has our membership increased? Well, we're sort of probably not unlike many of you on the phone in that we have problems in getting membership with our large healthcare systems. So my answer to this question is, it depends on how you're looking at it. If I were to, or I get revenue from the healthcare systems that employ the physicians, and I get the revenue from those systems to support the public health work. And so I'm getting money from the systems. It's not equated to individual membership, but it's equated to advancing the public health priority. So I'm engaging the system and many of the doctors within that system who are wanting to work on the public health priority for us. But because we are tied to the state association and with membership, I can't offer to the healthcare systems 100 memberships because the state would want to benefit from our financial grants that we got from the systems. And so that's been a barrier for us. And I've counseled some of my colleagues from across the state to think about that before you launch into a model like ours, if indeed you are going to do that. Because if you could equate it to membership at the onset, it's a lot easier than trying to go back and figure that out 4 or 5 years down the road. I hope that was clear. If you have questions about that, I'm happy to answer that as we go on here. How much non-dues revenue have you raised? Well, a lot. We've had a number of successful programs. We have really 4 categories of money, I guess. We have tobacco, obesity prevention, the end-of-life care, and then the convenings. Those are kind of our 4 major categories. And as we launched each one of them, we had a very modest, 10,000, 15,000, 20,000. But then as we grew over time, we started getting larger and larger grant dollars. So since the early 2000s, we've had about $5 million in grant success come through the society and through the foundation. And I know, having started this work 10 or so years ago, that would have freaked me out if I would have been listening to you or listening to this kind of presentation. And I get that, but it's also, this is a decade. So that when you look at your history and see the successes that you've made, some grants were really large. Like I had a $1.8 million grant. So obviously that kicks the number up quite a bit, but there is money out there. You just have to find someone that's comfortable in asking for money, and then you have to have a good idea and a project that physicians want to get their hands around and help you advance. How does the grant revenue help your society's finances? In a big way, actually. I have some of my grants have let me only take 10% off the top for overhead. Others have allowed much larger contributions. So usually I take 15 to 18% right off the top of the grant to support the infrastructure, so the rent and the IT and the HR and that kind of thing. So that is a huge number right off the top. And then in addition to that, sometimes I put part of my salary in there. We throw the medical director in there on occasion. I'm actually able to hire staff that are devoted to the issue in particular, so I don't have to stretch my current staff with, hey, here's another thing for you to do. I'm actually able to get dedicated staff. And at the some of our grants that we have that come to the society either go to the society, which is a 501c6, or it goes into our foundation, which is a C3. And so I have moving some money around on a monthly basis. I'm moving money around from the foundation to the society for that reason. So it's really helped. This is the main reason we're doing this work, quite frankly. I shouldn't say the main reason. From the financial perspective, this is the big ticket right here. It's keeping my lights on. How many staff members do I have? Right now I have 8. That's not a lot, but I have 2 that are devoted to tobacco, and I have 3 that are devoted to end-of-life care and the convenings. And then I have myself and an associate director, and then we have a part-time administrative assistant that comes in. But we have a whole heck of a lot of volunteers. And volunteers are primarily your membership, or my membership, but I would assume you would have the same. We have a lot of physicians that serve on our committees, but then in addition to that, we have physicians that we call upon to testify, and we call upon to meet with elected officials, and I really view them as, they're volunteer staff members. So we don't have a big staff, but we do big things. Who does the work on these projects? So I sort of addressed that a little bit. We have, as a medical society, I make it a priority for my staff to engage with our members in the work that we do, because it's very easy for us to go off on our own sort of tangent about working in a community and doing things in the traditional public health model, which is grassroots organizing. It's that kind of thing. But we can't lose sight of the fact that we're getting funded consistently for as long as we have, because we are engaging, empowering, and educating docs in this work. And so I do have dedicated staff people, and they almost always have an MPH, so that they're public health oriented. But then they also they're working with not only physician members, but we also have been successful in getting medical students to work with us for a service project. We've had that going on for a couple of years now. We have DNP students that are working with us as well. And we have interns that have come to us that are in their, they're finishing up their bachelor's degree, or they're entering into medical school because they want to partner with us in some of the work that we're doing. This one gets a little dicey. This is doing statewide work. So we are a large component medical society of our state association. And as we started our work, we didn't, especially in tobacco, we stayed in our lane when we started working on tobacco prevention, meaning we just worked in the 7-county metro area. And that was great during that time frame. But as time has moved on and the initiatives have come our way, we have expanded outside of our metro area and are working statewide in a number, actually in both tobacco and in end-of-life care. And it's because our state association hadn't prioritized that work. And the model that we created helped us to work with our other county medical societies who are looking for sort of that value proposition. So our model in Minnesota was to work with my colleague down at the Mayo Clinic and my colleague up in northern Minnesota to help them build a physician advocacy network within their region. And our state association we are now having discussions with them about, okay, how can we bring the MMA into our work in a bigger way? And I don't know what that's going to look like actually yet, but we're having that conversation. And then do you involve medical students and residents? Yes, we have a lot of medical students and residents that are involved in our work in a big way. Medical students, they have, in Minnesota, they have what they call SIGs, special interest groups, and some of them are focused on tobacco. We have a lot of medical students working with us on end-of-life care. And I'm only focusing on those two issues at the moment, but that's because that's kind of what we're wanting to offer through the Physician Foundation is those two areas. But medical students in particular, they're just on fire around in Minnesota. They're really wanting to get involved in public health priorities. They see it, they're interested in it, and they're just looking for a way to plug in. And so we've consistently worked with them. And the residents, they're a busier group of folks, but we do work with them as well. I'll just say one thing about the medical students and the end of life. We were lucky enough to be able to get to the right person at the University of Minnesota to talk about embedding advanced care planning curriculum in the fourth-year medical student ICU rotation. So now for the 3 years, we've been actually educating them about the Honoring Choices project and connecting them to the medical society in a kind of a tangible way. Okay, there we go. If there are any questions, we're happy to answer them at this time. It doesn't look as though there are any that we're seeing in the chat box at the moment.
You know, we actually do have just one here, and then if you have any others, please do feel free to enter them, or we can connect with you offline. But the one question we have is, how have your members reacted to this? How have they handled the shift?
Yeah, well, that's a good point. So actually, the sort of the old guard, I think I've had more of an issue with it in that they're wanting us to work on things that are at the Capitol, but that's really the state association's role. So I've been able to deflect those kinds of I guess concerns that have come my way to say that's not really our role. And also when I first started here, we prioritized public health as one of our top three priorities. And so our membership might very well have a concern about or a question about why are we working so much on public health, but it's clearly in our mission statement, and it's clearly a focus of the board. And so it hasn't really been much of an issue. So, Pete, I don't know if you have anything to add.
Yeah, thank you. So I think it's been a great opportunity for physicians to increase their level of engagement with the society, the medical society. And I think they really generally feel quite good about being able to contribute in a different way than what they could in their clinic. And there really isn't any other venue through which they can contribute on a bigger scale than this kind of an activity. So it's many people who do get engaged really find it very rewarding.
Right.
Excellent. Well, thank you very much, Sue and Dr. Donnell. We so appreciate your time today. In terms of next step for those of you, if this is something that you're interested in learning more about or exploring how this might be something that your society can do, I'll be sending out an email after this presentation, probably later this afternoon or tomorrow, with some more information about what are the next steps you need to start thinking about as an organization before you take this on, as well as a recording of this webinar. And with that, I'll send an invitation to you all to initiate a conversation with us so we can connect personally over the phone, and we can all start to have conversations about what this would look like in your state or your county and how we can have those conversations. So watch for an email from me. This is Annie, and we hope to talk with many of you very soon. Thank you all.
Thank you.